Today's guest, Dr. Jason Seiferman, is a triple board certified expert in pain medicine, rehabilitation, and headache medicine. He's pioneering genome-driven diagnostics for conditions like Ehlers-Danlos Syndrome, or EDS, and chronic pain, helping patients escape a diagnostic odyssey and find real answers. His work integrates AI, genetics, and regenerative medicine to revolutionize treatment. Today, we cover the challenges of diagnosing rare diseases and why many patients are left without answers, how genetic sequencing or DNA sequencing is reshaping pain management and precision medicine, and the future of AI-driven healthcare and what it means for you. This episode is packed with game-changing insights. Let's dive in. Dr. Jason W. Siefferman, medical doctor, a triple board certified physician specializing in physical medicine and rehabilitation and interventional pain medicine and headache medicine. He's a founder and medical director of Manhattan Pain Medicine, a multidisciplinary practice specializing in the diagnosis and treatment of complex pain. Dr. Siefferman has an interesting academic history with a BA in not only biology, but music from the Illinois Wesleyan University, with a study abroad experience in, coming from the University of Sussex in England. He earned his medical degree from Rush Medical College in Chicago before completing his residency and fellowship at Mount Sinai in New York City. Actually, he probably had some overlap with our founder, Dr. Brandon Kobe. So a deep commitment to innovative pain management. He's led research topics including spasticity and reduction, post-stroke, upper extremity pain in pianists, and alternative therapies for chronic pain. His expertise extends to rare disease diagnosis, including Ehlers-Danlos Syndrome, that's EDS, where he has helped reshape approaches to treatment through fusion of clinical experience and genetic insights. And currently his research interests include hypermobility, spectrum disorders, pelvic pain, pioneering new precision-based treatment models that integrate DNA-driven diagnostics with traditional pain management. Dr. Siefferman, welcome to the Smart Your Genes podcast.
Thank you so much. So happy to be here.
Well, we were talking and, I've learned you've been at this for, 10 years. And, that's pretty striking when I think back to, it was really, I think the dawn of the promise of precision medicine might have been around when, 2001-ish, right? When there was the promise of the human genome. And, here we are almost 25 years later, and you've been acting it out for 10 years. So, I'd really love to, do a couple of things here in our conversation. Again, I mentioned at the outset, this background in music, I think is really interesting. And I'd love to learn, how you jumped from, music to medicine and, how maybe that's even affecting how you run your treatment with that kind of, I would say, kind of holistic or harmonizing capability that is certainly highly trained. And then, we can dive in on some of this, really incredible work you're doing on the frontier of precision medicine, particularly the realm of rare disease and helping people end their diagnostic odyssey. But let's start with, how did we get from music to medicine?
Sure. I mean, I think these are two parts of the same brain. So I didn't necessarily make a jump from one to the other, but they're parallel tracks that have been coexisting for a long time. I knew from high school that I wanted to go into medicine because I like the diagnostic process. I like figuring out why things aren't working, how we can fix them, how we can make them work better. And simultaneously, I grew up in a musical family. It's been a part of my processing for a very long time. And, with music, you are not often by yourself. You're usually working with other musicians. And similarly in medicine, you have to work with colleagues and collaborate to provide the best outcomes. And similarly, we both have audiences, right? If you're a musician performing, you have to engage with your audience. And the same with doctors, you really have to engage with your patient. It's not enough just to know the stuff. You have to be able to work with the patient and find common ground.
Right. So you're really thinking here in terms of, the patient as a participant in the diagnostic process, let's say, and I've heard that over and over again, most notably by Lee Hood, who's over at the Buck Institute, specializing in longevity in this age of digital twins, where, he would describe that, the future of medicine is, precise, personal, and participatory. And, that is, certainly refreshing, especially as we, kind of dive into this notion of, rare disease in general, where there's because there's so few people that have these so-called rare diseases, there are so few people to serve them. And so they often find themselves on this diagnostic odyssey, going from, let's say, generalist to generalist before actually finding their community, their tribe. And, really interested to get your perspective on that as a clinician, somebody's in the field, helping people come to the other side of that odyssey. What's striking to you in these patient journeys and in the suffering that you've been seeing?
It's an unfortunate state of how healthcare is, that we're trying to adjust on the side of chronic pain, and especially with Ehlers-Danlos hypermobility spectrum disorders, because there's not a wealth of shared knowledge on any of these conditions. At best, there's limited knowledge, and even that knowledge is not broadly shared. So patients may see a variety of different specialists. Even within the EDS realm, there's a variety of specialists who claim to be EDS specialists, but they will each have their own vantage point, their own viewpoint, their own set of data that they're working with. They will have their own recipes, which may or may not work for each patient. So the biggest challenge I see when I'm meeting all these patients who have been through all this process is, first of all, confirming what actually is going on with their body. So there's this discovery phase with any new patient where we really want to understand everything that's going on. And this is where we really have to look holistically, and we have to consider, is there an autoimmune process beyond hypermobility? Are there other things causing pain? Is there migraine? Is there small fiber neuropathy? We really just do a deep dive to look for all potential pain generators. And then once we sort of have completed that survey and we have an understanding of what the potential players are, then we want to line them up and try to understand the relationship between them. Often by the time I'm seeing a patient, this pain has been going on, or pains have been existing for some time, and there will be primary pains and secondary pains and tertiary pains. So you really have to understand the interrelatedness between the pains. And for each of these pains, you have to understand why they're happening, how they came to happen, why they're not getting better on their own. Because to treat pain, that is what you have to treat. It's not enough to say this thing hurts, okay, let's numb it, or let's take a drug to shut it up. You have to understand why it's hurting, how it came to hurt, because that's what you actually have to treat.
Right. Because, pain can be the manifestation of many different root causes.
Exactly.
Yeah. And so you're focusing here on EDS specifically. Can you describe EDS in general, and what are the different subtypes and subtypes as they're currently understood by clinicians or patients?
Right. So Ehlers-Danlos, there's a variety of subtypes, and the most common are hypermobile EDS, which has no firm genetic basis, classical EDS, and vascular EDS. Those are the three most common. The first step is, if we're suspicious of EDS, is to confirm if there is classical or vascular EDS, because those have special medical considerations. We'll often get echocardiograms, do more thorough workup for these specific situations because of the complications that can arise. And this is where genetics are essential, because classical EDS and vascular EDS are genetic diagnoses. Hypermobile EDS, there have been genes that are associated with it, but there's no consistent, firm gene that is the cause. So hypermobile EDS and hypermobility spectrum disorders are generally thought of as the same, with the exception that there was a committee that decided consensus criteria for diagnosing hypermobile EDS versus hypermobility spectrum disorder. But when it comes down to the real life application for a patient in front of you, it really doesn't make a difference. So the first question there, do they have a genetic variant of EDS such as classical or vascular? If they do, there's a specific treatment pathway and workup pathway for those patients. If they don't, and it's hypermobile EDS, they're really grouped along with everyone who has hypermobility spectrum disorder, because it's all treated the same.
Interesting. Yeah. So, on that topic of hypermobile EDS, there's this preliminary association with, I think you probably know, the KLK15 gene. Okay, that's a great starting point. And it makes me think to, some conversations that I've been having with folks at HCM, hypertrophic cardiomyopathy. Lisa Salberg is the founder of the HCM4 Foundation, where she was a survivor, heart transplant, but what she had been saying for a long time was, okay, yeah, we're looking at these markers, but this is only a part of the story. And I don't think these are all of the markers. And just recently, you probably saw a couple of weeks ago, as there was a polygenic risk paper associated with HCM. Lo and behold, right? It's not this kind of Mendelian genetics paradigm. It's actually, wow, this like multiple contributing epistatic, concert or symphony of genetic interactions that are going on. And so, the thing that's really exciting is, okay, well, we have this, KLK15, for example, as a preliminary association. But, I understand EDS as an area that, is getting a lot more research and attention by comparison to, say, some of the other rare diseases. And so how do you as a clinician, kind of stay on top of the latest research and, kind of always be out there on the frontier? Because, this research, they call it research because you research, right? I mean, you're a rare breed in terms of a clinician that's integrating genetics that is so innovative and pioneering at this point. So given your patient load, how are you also balancing this innovation and this R&D?
Yeah, this is one of the challenges, because what needs to be done and what I want to do are balanced with the patient care in front of me. And so building out the practice so that we can accommodate the research that needs to be done, we can develop the educational materials and the support groups and everything that go around the treatment that we're providing. It's an essential part of the mission and vision of Manhattan Pain Medicine. So that is the ongoing growth struggle. How do I keep on top of this? There's a new tool, which is fantastic, called Open Evidence. And basically it's an AI search bot for PubMed. So it's the quickest and easiest way to, be as specific as you can with a literature search for what's out there.
Amazing. Yeah. I mean, these open AI tools that you're talking about, these chatbots, are pretty amazing. I know that, you're a user with the Sequencing.com platform, and it's been, fun to like chat back and forth across email in the beginning, like, hey, do you have this marker? Is there this marker? And I'm excited for you to get in there and leverage Genome Explorer as an example, right? So you take something like the OpenAI chatbot to the literature, PubMed specifically, and that's great. That gives you kind of an overall, lightning speed meta-analysis as to what's out there, which is like, wow, I would have loved to have that back in my graduate school days. But then in terms of okay, well, how does that relate to me? So then you go into like your sequencing account, and it's like, actually, it's your sequencing account and your genome queried against all of those findings, all of those variants that have research publications around them in databases like ClinVar, for example. So, it's like you had emailed me previously with a couple of variants, said, hey, do you check for these variants? And the good news is we check for all variants, and that all the variants are updated as often as every week based on the literature. And so it's a really neat, kind of step towards translational medicine. And now you can actually look at your, patient's genome and let it speak for itself, so to speak. And just again, the fact that you're out there, kind of on the cutting edge is really exciting. Because let's say one more thing. I had a chair of Koenig Institute of Health Research on, 2 episodes ago or so, who I interviewed. And, what he was talking about is being the dean of the medical school at Dalhousie University in Canada is like one of the biggest challenges is the strain on the practitioners. There's not a lot of time to go through, depending on which branch of medicine that they're in, to kind of do this deeper diagnostic. So it sounds to me like it's like, hey, if we can get the tools to automate the things that can be automated and get the clinicians to ask the questions that only they can ask, maybe that's where we're getting into. Is you said you love the diagnostic process. Well, what is that? It's a series of beautiful questions, right? So you've been doing this for 10 years. What kind of, results are you seeing? What kind of impact are you making on your patients?
So the most useful tool we've found for hypermobility treatment is regenerative medicine.
Mm-hmm.
So the core issue with hypermobility is laxity of ligaments. Ligaments are the structures responsible for stabilizing joints. When they are stretchy, when they are loose, the joints become hypermobile. When the joints are hypermobile, gravity takes advantage of them. They don't work in the most biomechanically advantageous way, and you have pain from that. and then you get guarding, and there's a whole trickle-down effect from that. So using regenerative medicine to trigger strengthening and increased resilience of those ligaments, tightening joint capsules, things like that. That's the best thing we found so far. But at the same time, there's not enough research to substantiate its use. So it really is sort of on the edge. Let me take a step back from that. These are techniques that have been around for many, many years. Prolotherapy was used in ancient Greece to treat hernias. So it's not a new technique by any means. It was practiced widely in medicine in the US up until the 70s and 80s when HMOs took over and decided not to pay for it. Then it fell out of practice. Before then, it was used pretty broadly for, sports and musculoskeletal injuries. But looking specifically at hypermobility spectrum disorders, people with intrinsic laxity, not sprain or injury-induced laxity, but intrinsic laxity, there's no clinical study looking at the effectiveness for any intervention of regenerative medicine.
Wow. Yeah. So is this, when you say regenerative medicine, to me, this sounds like you're prescribing specific exercises.
Not so much.
No, okay, sorry.
Exercises are essential for training muscle proprioception, which is position, sense, and space, for core strengthening, but this is all a substitute. So when the joints are loose, yes, you can use your muscles to hold things together, but that's not what the muscles are meant to be doing. So if they're busy holding everything together, they're not able to truly function and control the motion of the joint the way it needs to be controlled. This is how people with hypermobility get overuse issues. This is how you get rotator cuff tendinopathy. This is how you get bursopathy around the hip and all kinds of other muscle overuse pains, because the muscles are busy trying to hold everything together. This is how you get thoracic outlet syndrome with EDS, because the neck is unstable, so the scalene muscles tighten up to hold the neck together. They end up putting tension on the nerves that go between them, causing other problems. So if you can treat the intrinsic laxity of the ligaments and stabilize the joints, then the muscles don't have to do that stability job. They can do a function job, which is what they're meant to do. Mm-hmm. So PT is absolutely essential for getting people out of this guarding pattern and retraining the muscles to work functionally rather than reactively. But you can only do that once the intrinsic laxity is treated.
Right. And so when you talk about treating the intrinsic laxity, what specifically are the protocols in medicine? Yeah.
This is where we'll use injection of dextrose, which is prolotherapy. The sugar causes a chemical irritation to the ligaments, which stimulates collagen proliferation, which makes the ligaments grow and become stronger, so they're more resilient. We'll also use platelet-rich plasma. This is where we draw the patient's blood, spin it down, we get the platelets. The platelets simulate an injury, which stimulates a healing response from the body. And that can very robustly repair torn, injured tissues.
Got it. Wow. Okay. And how many clinicians are doing this kind of treatment, in the US or globally? Could you estimate that for this?
That's a great question. We don't actually know. So again, this is an area of medicine where the standard of practice is not established.
Yeah.
It's where a number of different providers have either learned from other providers or figured it out on their own, and they've developed their own recipes. And it's the analogy I make to patients, it's very much like going to a different bakery, right? Like some may have cinnamon in their apple pie, some may have raisins. They're each going to have their own recipe for their crust. There's not a standardization here. And this is reflecting back to where we do need research, clinical controlled studies with people with hypermobility, evaluating these processes just to see what is effective for whom it's effective. And this is where the genetic piece is an essential piece, because the presentation of hypermobility spectrum disorders is broad. I may have patients where their hips, shoulders, ankles are hypermobile and their spine is not. I may have patients where their spine is hypermobile, but their hips, shoulder, ankle are not, right? There's an entire spectrum of presentation, and the genes may be the key to understanding who falls into which category, and they may also be helpful in guiding which therapies will be most responsive. So for example, not everyone responds to prolotherapy. The vast majority of people do, but not everyone does. And then the next question is, for those who respond, how long does it last? Because their ligaments are stretchy, surely they will stretch back out. The idea is we make the ligaments strong enough that they can support the stress of weight and gravity but eventually they may stretch back out, and some people do and some people don't. We don't know who those people are. So if we have the genes associated with this in advance, we may be able to better predict which therapies will work for which patients and save them the trouble of trial and error.
Yeah. Well, I like that you're basically co-opting this treatment. Like you said, it's been, tried on athletes. I think you said to some extent, right? Athletes who've been injured. And, in my previous life as in human performance as an advisor to athletes, it's expansive network of care providers. And one of them was, exactly in this realm, like an MD, focused on, athlete return to play. But his whole, evidence-based practice focused on the highest performers that you could imagine, integrated these different kinds of modalities, in addition to things like, peptides or growth hormone or stem cells, PRP, platelet-rich plasma, et cetera. But you're right. There was no universal playbook, right? There were like, you can't just say, here's a cocktail for all athletes. Like every athlete was a case by case organism, right? And its entire biology was considered, their sport, their injury history, their genetics, their goals, right? And so that's very, very expensive. And, this was something that was being delivered, as long as, say, 15, 20 years ago. So now all the different technologies, coming together, the digital technologies to probably accelerate the research that you're doing and the studies and the collaboration. That's pretty exciting. And, I did have, a question for you about, those who are resistant to integrating genetics, because you mentioned this is a critical piece. Well, I've talked to, a lot of people who they have their whole genome sequence and their clinician doesn't want to look at it, doesn't want to consider it, or say it's not there yet. What is different about your mindset? Like, were you born knowing that, or was there an aha moment for you where you're like, I need to make this a critical part of my care solution?
There's always the question of what are we going to do with this?
Yeah.
So it's the same if we do any lab work, if we do any imaging, what are we going to do with this information? Just because someone has a specific gene doesn't mean they're expressing that gene. Mm-hmm. And even the expression of the gene can be varied. And sometimes this is helpful. Let's look at the methyl tetrahydrofolate reductase, the MTHFR gene, right? Like that's pretty common. A lot of people are familiar with that. And it's easy enough to kind of test, right? Like if you don't tolerate eggs or broccoli or sulfur, or if you have histamine intolerance, some of these things, you can work around that and you can make sense of that. But at the same time, I have patients who have the MTHFR mutation and they have no issues with any of these things. And how do we make sense of that? So having the gene in front of you and reacting to it without a good reason or understanding or proof that it's even an issue, I think that's the biggest challenge that providers face at the moment. Mm-hmm. It's the same thing. I'll have patients come in with back pain and they're like, yeah, I've got a disc herniation in my back. I don't just jump to the conclusion that the disc herniation is causing that pain, because 50% of people without back pain have disc herniations. So right. A lot of things cause back pain. Like just because you have that disc doesn't mean it's causing that back pain. And what if it is that disc and something else, not just the disc in isolation? And the same thing with the genes, right? So this is where AI is going to be essential to really put all of this together. And I think in terms of implementation, I think even AI can generate the appropriate questions to ask to link whether certain genes may be relevant in a specific patient or not.
Right. Okay. So, but this probably has a lot to do with your own knowledge base in the context of the patients that you've served in the area of research that you're focused on within the broader sphere of medicine. And then right. So it kind of sounds like you've got, potentially the Dr. Seiferman LLM from all the work that you've been doing to kind of accelerate, the diagnosis just through your experience. Is that kind of what you're thinking? And then you kind of can share that knowledge with others and kind of like, put these different knowledge resources together in a vastly accelerated way because of AI.
I mean, I think we all have lots of hopes for AI. From the genetic standpoint, yeah. I'm considering what might we be missing? How much more specificity in the definition of this process can we get? And how much predictability of treatment success can we find? If we can align a genetic database with patient phenotype and outcome, then that can build and grow and give us predictive values.
Right.
So even at the moment, looking at predictive values for low back pain outcomes with an epidural, for example, we don't have that. And we should be able to have that. But I mean, there's a lot of statistics that are required to build that engine, which have not been collected because medicine as a practice in the US is siloed. Denmark or Sweden could probably come up with this, but you need the infrastructure for collecting data that we do not have. So that I think is the biggest challenge. But to kind of answer the other part of your question, the goal, or one of the goals of Manhattan Pain Medicine, is to share our understanding of these processes with the world. EDS, hypermobility spectrum disorders and associated conditions, have necessary workup to clarify everything that's going on and understand the interrelatedness of each of these things, and then put them in an order of importance for treatment. I can give you an example. So craniocervical instability, CCI, this is where the head-neck junction is loose. As a result of this, you can have impaired outflow of the cerebrospinal fluid. You can have compression of the jugular vein. You can have joint instability at the OA joint or the AA joint. You can have tension on nerves as they exit the head from the foramen magnum. The vagus nerve is a popular target because that's then associated with gastroparesis and other GI symptoms that come along with this. And then there's all the muscle guarding and the pain and the headache and everything that happens along with this. These patients can present a variety of different ways. They may just come in with blurry vision. They may come in with intracranial pressure issues. They may come in with sitting intolerance or reading intolerance or double vision after a specific amount of time. The point is, we have to take a step back, recognize that this is part of a larger picture as part of craniocervical instability, and screen for all of these other associated issues with craniocervical instability, not look at it just as the symptom they're coming in with and thinking that's the end of it, because it's generally not. It's usually 3 levels higher. So we have to understand that these happen in the scope of this larger process, screen the patient for each of these things, have a workflow for working up each of these things to see where the patient is with each of these things, because they all interrelate, they all cross-reference and affect the patient's experience. Put all of that together and then come up with treatment priorities for which do we think is at the highest, causing the most issue, and then how do we work down from there. That's part of the discovery process that we do with new patients to understand that, and then roll that into the treatment process, where we then start to understand how they respond to different treatments, what treatments they do respond to. Everything we do along this process gives us more information, and that's where the discovery is ongoing. And just putting all of this together and putting it out there. But anyway, there is a workflow for this. There is an outline for this process. And this is what we want to share with the world, so patients can have access to this and sort of see where they are. And they may recognize other things that are happening that they didn't think were connected, but now they suddenly see the link and they see how that connection exists. And then they know where to go to get that process worked up.
Right. So you're based in Manhattan, correct?
Yes.
As the name would imply, Manhattan Pain Medicine, right?
Yes.
So are all of your patients and clients, are they all in Manhattan, or do you do some version of telehealth as well? Like, what does the day-to-day look like for you?
So mostly in person, just because we can do consults remotely. We can't provide medical care remotely, but we can do consults, like educational consults remotely. But so much of what we do, the diagnosis is physical. I need to lay my hands on patients and see what's actually happening with their bodies to understand, first of all, mechanically what's happening, but also to understand the interrelatedness. There's a lot of information that I get just from seeing the patient move on the table, or just from their reaction to pressing on a specific structure, that I could never get from a questionnaire or from a telemedicine visit.
And so how many doctors are there like you in the world?
I have no idea.
I know that was an unfair question. And
Let's say one.
right. Well, we know one for sure. Yeah. I mean, the reason that I ask is because, so many people come to sequencing for, to get to, at least the genetic root cause, the underlying cause of EDS. But it would be great to be able to connect them to additional, resources or centers of excellence or centers of care. And so, are there other, I know there is the EDS Foundation, but, beyond that, what other resources would be available to those people?
The EDS Society is probably one of the best collective resources.
Yeah. Yeah.
That's a great place for people to start.
So, look, I know I only have you for a short period of time, and there are lots of folks waiting to see you. And I just wanted to, kind of end with, 3 kind of rapid fire questions to kind of, focus on the main points of today's discussion. And I think you may have saw them at the outset. Really, it's like, if this was your last podcast, what's the message we want to share with the world that's come out of this dialogue? And number 2, who needs to hear it? And then, number 3, who would you nominate to be on the show? So the first question is, what's the key message here that we need to get out and for whom?
With pain, you have to understand the how, what, and why. It's not enough to say it's one structure causing the pain. You have to understand why that structure is causing the pain. And just like you reverse engineer any other problem, you may have to ask 5 whys to get to the actual root cause. Mm-hmm. Without uncovering and treating the actual root cause, long-term success of treatment is low.
And who needs to hear that?
Anyone with any chronic pain issue. It's not getting better for a reason. You have to figure out that reason.
Okay. And the third question, who would you nominate to be on the podcast?
Arthur Jenkins, my friend. He is a neurology and spine surgeon who specializes in some of these more esoteric conditions like craniocervical instability, Bertolotti syndrome, a lot of these EDS-associated conditions that are not widely treated surgically, but there is a time and a place for appropriate surgical intervention, and few people have delved into the nuance at the level that he has.
Amazing. Okay, well, I'll follow up with you to get his contact. One other thing that we wanted to do, Sequencing wanted to do, for you to support all the work that you're doing, gift from Dr. Brandon Colby to you, Dr. Jason Seiferman, is, we run a Families in Need program because we know not everybody can afford genome sequencing. And so we'd like to donate 5 whole genome sequencing to your practice and to your initiative. And, we can't thank you enough for spending the time with us today to, communicate the initiative that you're working. So, we're really proud to be working with you. And that's I suppose a gesture of our appreciation.
No, thank you so much. Those will be very much appreciated. Thank you.
Well, it's my pleasure. And again, Dr. Seiferman, thank you. I know you have limited time for spending it with us today. And I'm really excited to share this with the listeners at Sequencing.
Great. My pleasure.
Today, we uncovered how genomics is ending the diagnostic odyssey for patients with EDS and chronic pain. Dr. Seiferman's insights show how the future of medicine isn't just about treating symptoms, it's about understanding the root cause and including genetic intelligence in that assessment. If you've ever felt unseen in healthcare, hopefully this episode resonated with you. And what's more is, if the conversation opened your eyes to the power of personalized medicine, please share it with someone out there searching for answers. This might be the episode that changes their life. Please subscribe to the podcast and spread the word, and let's help more people outsmart their genes together.